I want to tell you something that took me years to fully accept. After 13 years in emergency medicine, after working thousands of shifts, after standing at the bedside of more cardiac patients than I can count, I realized that the story we tell the public about heart attacks is incomplete in a way that is genuinely costing lives. Not wrong, exactly. Incomplete. And in medicine, incompleteness is often just as dangerous as wrong, because it gives people a false sense of where the risk is actually coming from. The story most people have been told goes roughly like this. Heart attacks happen to people who are overweight, who smoke, who don't exercise, who eat badly, who have high cholesterol. They are the predictable consequence of obvious lifestyle failures. And if you avoid those things, if you stay lean, if you exercise, if you don't smoke, if your cholesterol comes back normal, you are not in that category. You are safe. I have watched that belief, that comfortable and deeply human belief, cost people their lives. Because the single most consistent thing I have realized after 40,000 emergency cases is not about the heart attacks I have seen. It is about the ones that shocked everyone in the room. The patients who had done everything right. The ones whose families stood outside the resuscitation bay saying the same thing over and over in genuine bewilderment. But he was so healthy. But she had just had a checkup. But there was no warning. There was nothing. Except there was. There almost always is. And it was almost always missed, not because it was hidden, but because nobody was looking for it in the right place. Hi, my name is Dr. Miles, emergency medicine physician with 13 years of frontline experience. What I want to do in this video is share the most important thing I have learned about heart attacks from the inside of an emergency department. The thing that the standard public conversation about cardiovascular disease consistently gets wrong, because understanding it may genuinely be the difference between catching your risk early and discovering it too late. The heart attack nobody expects is the most common kind. Here's the first thing I want you to understand, and it reframes everything that follows. The majority of heart attacks do not happen in the patients everybody expects them to happen in. They do not arrive exclusively in the severely obese, the heavy smokers, the completely sedentary. A significant proportion of first heart attack studies suggests somewhere between 50 and 75%, depending on the population, occur in people with no prior cardiac diagnosis, no dramatic risk factors, and no symptoms that would have flagged them as high risk by conventional screening criteria. These are the patients who terrify me most, not because their cases are more medically complex, but because they had every reason to believe they were safe. Their last blood test was normal. Their doctor told them their cholesterol was fine. Their blood pressure was borderline, but not alarming. They were active enough. They were not overweight enough to worry anyone. And then they are in front of me. What this tells us, what 13 years of seeing the full spectrum of cardiac patients has made absolutely clear to me, is that the standard risk framework we use to identify who is at risk of a heart attack is missing a very large portion of the people who are actually going to have one. We are screening for the wrong things in the wrong way, and leaving an enormous number of people entirely unaware that the process driving their future heart attack is already well underway. What is actually happening inside the artery? To understand why the standard approach misses so many people, you need to understand what a heart attack actually is at the biological level. Because most people have a picture of it that is about 20 years out of date. The old model, fat sticking to the walls of arteries, like grease in a pipe, is wrong in ways that matter enormously. Coronary artery disease is not a plumbing problem. It is an inflammatory disease of the arterial wall. And the distinction is critical. Here's what actually happens. The process begins with damage to the endothelium, that extraordinarily thin layer of cells lining the inside of every artery in your body. When the endothelium is injured, inflamed, or chronically deprived of nitric oxide, it becomes permeable and reactive. LDL cholesterol particles penetrate the arterial wall. The immune system identifies them as a threat and sends white blood cells to attack them. An inflammatory response begins inside the wall of the artery itself. Over months and years, a plaque forms not sitting on the surface of the artery, where it would cause obvious narrowing and symptoms, but buried inside the wall, invisible to symptoms and invisible to most standard tests. And here's the part that changes everything about how we should think about risk. The plaques most likely to rupture and cause a heart attack are not necessarily the largest ones. They're the most inflamed and most unstable ones. A relatively small plaque with a thin fibrous cap and a highly inflammatory core can rupture suddenly, trigger an immediate clotting response, and block the artery completely within minutes. That is a heart attack. And it can happen in an artery that was causing no symptoms, no chest pain, no detectable narrowing on a standard assessment because the plaque was not big enough to restrict blood flow. It was just unstable enough to kill. This is why a normal cholesterol test does not tell you whether you have dangerous plaques in your arteries. This is why a normal stress test does not guarantee safety. This is why people who were told they were fine end up in my department. The tests we routinely use were not designed to detect small, unstable, inflamed plaques. They were designed to detect severe narrowing and very high cholesterol. And severe narrowing and very high cholesterol are not what cause most first heart attacks. If this is giving you a picture of cardiovascular risk that you've never been given before, I want to ask you right now to subscribe to this channel. I make these videos because this gap between what the public is told and what emergency medicine actually sees is enormous and consequential. Every subscription genuinely helps this reach further. Hit the button and let's keep going. So what creates the inflammatory environment that destabilizes arterial plaques and drives the heart attacks that nobody saw coming? This is the question I keep returning to, and the answers are both more specific and more actionable than most people realize. The first driver is chronic systemic inflammation. Inflammation is the engine of the process I just described. The endothelial damage, the plaque formation, the instability that makes plaques rupture. And the sources of chronic, low-grade inflammation are not limited to the obvious ones. They include chronically disrupted sleep, which elevates inflammatory markers including C-reactive protein and interleukin-6 even in otherwise healthy individuals. They include chronic psychological stress, which activates the immune system through cortisol dysregulation and sustained sympathetic nervous system overactivation. They include visceral fat, the fat stored around internal organs, rather than under the skin, which secretes a continuous stream of pro-inflammatory signals directly into the circulation, even in people who appear lean externally. None of these show up in a standard cholesterol panel. None of them trigger a referral to a cardiologist. All of them are quietly advancing the disease process for years before anything catastrophic happens. The second driver is insulin resistance, and I cannot overstate how central this is to the heart attacks that surprise everyone. Insulin resistance does not announce itself. It does not feel like anything. It does not reliably show up as elevated blood sugar on a fasting glucose test until it has been present for years. What it does, silently and persistently, is damage the endothelium, elevate triglycerides, shift LDL toward the small, dense particles most likely to penetrate arterial walls, and drive the inflammatory environment in which plaques form and destabilize. Insulin resistance is not a prediabetes problem. It is a cardiovascular problem that sits at the center of most premature heart disease, and it is detectable years before it causes any obvious metabolic symptom if you measure the right thing. The right thing to measure is fasting insulin, not just fasting glucose. Fasting insulin reveals the compensatory hyperinsulinemia of insulin resistance long before blood glucose becomes abnormal. It is a cheap test. It is widely available. And it is almost never ordered as part of a routine cardiovascular workup, which means the people who most need to know they have it are the last to find out. The third driver is a genetic marker called lipoprotein A, LPA. LPA is a highly atherogenic variant of LDL that is determined almost entirely by genetics. It cannot be meaningfully changed by diet or exercise. It is not included in a standard lipid panel. An elevated LPA is one of the most potent independent risk factors for premature coronary artery disease and heart attack that exists present in approximately 1 in 5 people, invisible unless specifically tested for and responsible for a meaningful proportion of the heart attacks that arrive in people with otherwise normal cholesterol profiles. The test that changes everything. If there is one investigation, I wish every person over the age of 40 would have one single test that would identify silent coronary artery disease. Before it causes a catastrophic event, it is a coronary artery calcium score. A coronary artery calcium score is a low-dose CT scan that directly images calcification within the coronary arteries. Calcification is a marker of established atherosclerotic plaque. A score of 0, no detectable calcium, confers a very low near-term cardiovascular risk, regardless of other risk factors. A significant score tells you that the disease process is already advanced, that the window for the most impactful intervention is closing, and that aggressive risk management is warranted immediately. This scan takes minutes. The radiation exposure is low. The information it provides is more predictive of future cardiovascular events than any combination of standard blood tests. And it is not part of any routine screening program for most people. The patients who would benefit most from knowing their calcium score are the ones who feel healthy, whose standard tests look reassuring, and who have no reason to believe they are at risk. Because those are precisely the patients whose disease is most likely to go undetected until it is too late to detect anything. After 13 years and 40,000 emergency cases, here is what I know with complete certainty. Most heart attacks are not a surprise to biology. They are surprises to the person. The process that produced them was running for years, detectable, measurable, interruptible, in a body that felt completely fine and was being told it was completely fine by tests that were not designed to find what was actually there. The gap between what the standard cardiovascular check measures and what actually drives most first heart attacks is wide enough that people fall through it every single day. Fit people. People who took their health seriously. People who had no idea that their arteries told a different story from their cholesterol result. Know your fasting insulin. Know your LPA. If you are over 40 and you consider yourself low risk, consider a coronary artery calcium score and understand that a normal cholesterol test and a clear stress test are not the same thing as a safe cardiovascular system. The heart attack nobody expected did not come from nowhere. It came from a process that nobody was looking for. And the only way that changes is if you start looking. If this video gave you something the standard conversation never has, please subscribe to this channel and share it with someone who believes their normal checkup means they are safe. That belief is the most dangerous one in cardiovascular medicine. Thank you for watching.